Okay, I think I'm going to get started here. We have about 51 people in the room, and so I just want to do some introductions. I want to welcome everybody to this Learning Community Series webinar produced together with the California Prevention Training Center and the Hawaii State Department of Health. And we are going to be discussing the concerning rise in maternal and congenital syphilis in Hawaii. And we are joined today by my esteemed colleagues who I'm going to introduce. Starting from the left is Dr. Sharon Adler. She is an assistant clinical professor at the UCSF School of Medicine in the Department of Family and Community Medicine. And she's also faculty from the California Prevention Training Center. And then moving right along, we have Glenn Wasserman, who is the chief of the Hawaii Department of Health Communicable Disease and Public Health Nursing Division, as well as Acacia Fukuda, who is an intervention specialist with the Hawaii Department of Health Harm Reduction Services branch. So now I'm going to talk to you a little bit about some webinar housekeeping. So for you guys, this attendee speaker will be turned off during the webinar. The attendee video will be turned off during the webinar, and the chat is going to be turned off during the webinar. But we would love to have you send us your questions and answers, because the Q&A will be on during the webinar. And let me just go over that for a second. So the Q&A process is that anyone who is attending the webinar can submit their questions to the hosts or the panelists during the webinar and up until the remaining 2 minutes of the Q&A session. So our hosts, who are not on camera right now, are here to are Elizabeth and Lauren from the California Prevention Training Center, who are going to be handling any sort of logistical issues you might be having or any questions about sort of housekeeping around the webinar. If you have content related questions or clinical questions that come up, those will be answered by our panelists. And to submit a question, you're going to click on the Q&A icon in your control panel to open the Q&A chat window and go ahead and type in your question in that Q&A box and hit send, and we will receive them. And I will be sort of triaging them throughout the lectures that happen today. So a little bit about our training center. So we're a multidisciplinary training capacity building assistance center, which has been funded by CDC for more than 25 years. And we are part of the national network of clinical STD prevention training centers. And you'll see that there are 8 of us that are covering the United States as well as Puerto Rico and the Virgin Islands. And our area in California covers California, Nevada, Arizona, New Mexico, and of course, the great state of Hawaii. And just so you know that this activity is eligible for CME, we are provided CME by the University of Nevada, Reno School of Medicine, and this particular activity will qualify for one category through the AMA, one hour of CME. So basically, upon meeting the CME requirements, which just means you need to fill out an evaluation and let us know what you thought of the course, you can collect your certificates approximately 6 to 8 weeks after the completion of the course, and you'll receive instructions on how to do that online. And the most important piece of this is that you do a course evaluation to receive your CME. Here are financial disclosures. Basically, there have been no financial disclosures by anyone who's speaking on this webinar today, nor by any of the families of those who are speaking today. And if you have any questions, please direct them to our clinical program manager, who is Elizabeth Olson, and her email is here. It's elizabeth.olson@ucsf.edu. And so I am now going to turn it over to Glenn Wasserman, who is the chief of the Communicable Disease Control Division and Public Health Nursing at the Hawaii State Department of Health. Take it away, Glenn.
Yes, thank you, Dr. Park. I'm going to show you a lot of data. So before I start, I want to share with you the key points of my presentation. First, there it goes. First, that beginning in 2018, Hawaii has seen an upsurge in primary and secondary syphilis in women. Then in this year, we've seen a dramatic increase in cases of congenital syphilis, with 10 cases so far this year. Risk factors associated with Hawaii's congenital syphilis cases are being Pacific Islander, having late or no prenatal care, inadequate treatment of the mother's syphilis during pregnancy, and to a lesser degree, maternal alcohol and drug use. This slide shows rates of syphilis in the United States since 1941, with peaks associated with World War II and the AIDS crisis. Notice that around 2012 in the US, we have a marked increase in primary and secondary syphilis, as well as early latent syphilis, which are the most infectious forms of person-to-person transmission of syphilis. Here we see rates of primary and secondary syphilis in the US in both males and females during the upsurge in syphilis that began in 2012. First thing you'll notice is that the number of male cases greatly exceeds female cases, mostly in men who have sex with men, and this has been associated with online pickup sites like Grindrs, which facilitates anonymous sex among partners. Rates of primary and secondary syphilis in Hawaii also show a higher male to female ratio. You should particularly note that in Hawaii, female cases show a marked increase from 2018 to present. This slide shows a comparison of rates of primary and secondary syphilis by state in the US. Hawaii ranked in the middle, 28th of 50 states in 2018 at 6.4 per 100,000, which is below the mean of 10.8 per 100,000 for the entire US. An important point is that Hawaii's rate of increase in primary and secondary cases is now amongst the highest in the US. Most of the cases of early syphilis in females occur in Honolulu County, as shown by this representative slide. In Hawaii, the distribution of primary, secondary, and early latent syphilis, as I mentioned before, the most infectious stages for person-to-person transmission, are about the same for males and females. However, the distribution of late latent syphilis or unknown stage syphilis is higher in females, reflecting the effect of pregnancy screening in identifying late stage syphilis, which can also result in congenital syphilis. In the US and surrounding territories, we note that the rates of primary and secondary syphilis are higher in Blacks, followed by Native Hawaiian and other Pacific Islanders, which is the second highest group in the US, and American Indian and Alaska Natives. As you'll notice in the pie chart reflecting Hawaii's recent racial distribution of primary and secondary syphilis, cases are disproportionately higher in women who are categorized as Native Hawaiian and Pacific Islander, and in 2019 accounted for 54% of the overall cases, reflecting the need to provide greater attention and efforts in this group. About half of those cases were Native Hawaiian, with the other half primarily found in Chuukese and other federated states of Micronesia patients. Let's turn our attention now to congenital syphilis and how we define this. Most cases of congenital syphilis are probable cases rather than confirmed. Probable cases include when the mother has untreated or inadequately treated syphilis at delivery of a stillbirth or live infant. Adequate treatment is defined as completion of a penicillin-based regimen in accordance with CDC treatment guidelines appropriate for stage of infection, which was initiated 30 or more days before delivery. Penicillin is the only acceptable treatment for pregnant mothers who have syphilis. So if they are allergic to penicillin, they must undergo penicillin desensitization. Probable cases also include when the infant has a reactive non-treponemal test, such as a VDRL or RPR, with any evidence of congenital syphilis on physical exam, CSF evaluation, or radiographs of the long bones. Only when a case is laboratory confirmed do we consider this a confirmed case of congenital syphilis. Laboratory confirmation of congenital syphilis can be made using dark field microscopy, PCR or other equivalent direct molecular methods, or immunohistochemistry or special stains of specimens. Congenital syphilis has been on the increase in the United States since 2014, with a progressively increasing rate of rise. In Hawaii, we've seen increased numbers of probable congenital syphilis around the same time as in the US, with a marked increase noted in 2020. We currently have 10 reported cases of probable congenital syphilis since the beginning of the year and are anticipating an additional 2 cases recently. When we look at those recent cases of congenital syphilis in Hawaii, you notice that almost all cases of congenital syphilis were in the native Hawaiian Pacific Islander category. This makes sense when one realizes that congenital syphilis is associated with the complex interplay of social determinants of health and access to care, and includes poverty, unstable housing, language, educational and cultural differences, and access to both transportation and prevention and care health services. Patients in this group were about a third Chuukese, a third Marshall Islander, with remaining cases of congenital syphilis found in non-Chuukese patients from Micronesia, from Palau, and in native Hawaiians. Consequently, it is of special importance to consider this demographic for enhanced testing, treatment, and follow-up when assessing for congenital syphilis. Late or no prenatal care is often associated with congenital syphilis in the US. In Hawaii, as shown in this slide, most of the cases came in during the second trimester, with only 1 patient in the past 4 years coming in for obstetrical care during the first trimester. In Hawaii, inadequate treatment of the mother for syphilis is a significant risk factor for probable cases of congenital syphilis, with only 1 of 18 mothers of a baby with congenital syphilis having adequate treatment of syphilis during pregnancy since 2016. Maternal substance abuse is another important risk factor associated with congenital syphilis in Hawaii, although to a lesser degree than race, late prenatal care, or inadequate treatment of the mother. So to summarize, beginning in 2018, Hawaii has seen an upsurge in primary and secondary syphilis in women. Then in this year, we've seen a dramatic increase in cases of congenital syphilis, with 10 cases so far this year. Risk factors associated with Hawaii's congenital syphilis cases are being Pacific Islander, having late or no prenatal care, inadequate treatment of the mother's syphilis during pregnancy, and to a lesser degree, maternal alcohol and drug use. I'll turn this now over to Acacia Fukuda, our disease intervention specialist with the Harm Reduction Services Branch. We'll go over syphilis case investigations and partner services at the Department of Health and how the Department of Health can assist you.
Thank you, Dr. Wasserman.
I'm trying to convert this over now. Let's see. Can you release my, there it goes, okay. Now I can release it.
All right. Yes, thank you so much, Dr. Wasserman. My name is Acacia Fukuda again. I work with the Hawaiʻi Department of Health, and today I'll be talking about syphilis case investigations, as well as partner services. I'll be giving an overview of our program and surveillance activities. I'll share with you how we conduct syphilis case investigations, and I'll also discuss how the Department of Health, providers, and community organizations can work together to address syphilis in women as well as congenital syphilis. So the STI and HIV Prevention Program here at the Department of Health works to prevent further transmission of STIs and HIV, as well as the complications caused by these untreated infections. We do this through several activities, including screening, the medical management of diagnosed patients, referral of contacts to medical care, consultation, education, and training activities, as well as surveillance and epidemiological activities to monitor STIs and HIV in the general population. Surveillance is an important component of our program that informs us of the burden of disease that exists in our community. To best track the cases of syphilis in Hawaii, we rely on the reporting of infections to the health department. Case reporting is just the process of reporting cases or reactive serological laboratory results of notifiable infectious diseases to state health departments, and that's done by providers or laboratories. In Hawaii, reporting of STIs and HIV is mandated by law for healthcare providers and for laboratories. Reportable STIs include syphilis and congenital syphilis, but it also includes gonorrhea, chlamydia, pelvic inflammatory disease, as well as HIV and AIDS. And this all must be done within 3 working days of confirmation. For healthcare providers, the information that needs to be reported includes, but is not limited to, the patient's contact information, demographic information, the date of diagnosis and treatment, and type of treatment, the staging of the infection, and recent sex partner information. Syphilis, as well as other reportable STIs, can be reported to our program via faxing or mailing a case report, or by calling in to report a case. We'll be sending an email after this with information about case reporting. And that information is also available on our website as well. Just keep in mind that HIV and AIDS is reported to a separate program within our branch, and that information is available on our website as well. Laboratories are mandated to provide reactive serological results to the Department of Health, and this flow chart here describes a typical scenario about how that happens. But this, of course, does not cover all scenarios, such as if the provider or facility uses a reverse algorithm for testing. But in a typical scenario, the provider might first order a syphilis test, such as the RPR with reflex to titer, through a local private laboratory. Keep in mind that some serological tests for syphilis may go out of state first. Some include the FTA-ABS or VDRL test, and thus takes longer to result and have a aliquot of that reflex to our state lab. So for this reason, the provider might find that the RPR with reflex to titer is a more ideal test. After a specimen returns reactive, they are required by law, the laboratories, to have an aliquot sent to our Department of Health lab, and that's for confirmatory testing with the TPPA, which is just a type of treponemal antibody test. Our lab also performs a qualitative RPR and quantitative RPR on that specimen, and all results are reported to our STI surveillance program. The results are reported back to the provider as well, and that's done via the original private lab they ordered it through. So now we'll talk about the epidemiological activities that we do, which are really centered around syphilis, as well as other STIs prevention and control efforts. So many of these activities are carried out by our disease intervention specialists, or DIS. You might also hear them referred to as IS, but they're public health professionals, and they take on many roles to protect the health in their community. There are DIS located across the nation. They work in their local or state health departments. Most recently, some of our DIS have assisted with local COVID-19 contact tracing. So we're really proud of them, and we're really thankful for them for stepping up in that way. But DIS are skilled. They're boots on the ground workers, and they have expertise in different areas, such as linking patients to care, education and counseling, provider and community engagement, as well as case investigations, where they perform contact tracing and partner services. And they're the ones who are truly contacting patients by all means, whether it be showing up at their doorstep, showing up in a park, or trying to locate them somewhere in the public if they're houseless. They're doing everything that they can to refer these patients and their partners to medical care. So they conduct case investigations, and the purpose of these case investigations are to prevent the transmission of STIs and HIV and to reduce suffering from their complications. When conducting a case investigation, the DIS interview patients, they locate their sex partners, which is the contact tracing portion, and they refer them to medical care. A term that comes up a lot in STI prevention is partner services. And that basically refers to a wide range of services that are offered to patients and their sex and or needle sharing partners. But it's largely focused on getting these patients into medical care. Partner services are always client-centered, they're confidential, voluntary and non-coercive, and best of all, they're free. That was a lot of information. We're going to summarize it here in this workflow that basically outlines how a case starts and what we do throughout that investigation. So like I mentioned earlier, we learn about these cases either from healthcare providers or laboratories that gets reported to our STI prevention program. And the STI prevention program then prioritizes cases for follow-up. So not all positive labs will be investigated. That's important to know. But they go through an algorithm in order to prioritize them. But just know that positive serology in infants, females of reproductive age, and especially pregnant women are always prioritized and investigated. Cases are assigned to a DIS who will then proceed to contact that healthcare provider who ordered the test, just to ensure that adequate treatment was given. The DIS will then ask the healthcare provider pertinent questions that help in the investigation, such as if the patient is experiencing any barriers to returning for treatment, or of course, if they're female, if they're currently pregnant. The DIS will then attempt to locate the patient in order to complete the interview. This interview can be done while the patient is in the provider's office, either by getting that patient on the phone in the office or by having a DIS going down to the provider's office in person to meet the patient. Of course, this has been complicated by COVID-19, as we're trying to limit the amount of people and the amount of time that's spent in the provider's office, but that's what typically would be done. But having that patient being connected to the DIS while they're in the provider's office is really important and helpful, especially when we're working with patients who may not have a phone or are instably housed. The patient interview consists of questions that are aimed towards collecting information about risk behaviors and demographics. If it's revealed in the interview process that a patient is in need of further services, we can make referrals at that time as well. Some of those common referrals include a referral to HIV or gonorrhea and chlamydia testing, as well as referrals to pre-exposure prophylaxis for HIV services. One of the most important aspects of the interview, of course, is partner services. And that's the elicitation of sex partner information from the patient so that we can make an anonymous notification to that person and refer them to care. But partner notification is not just limited to the DIS and the Department of Health. We encourage partner notification by the patient, and we also encourage providers to be involved in this process as well, as they tend to have a better rapport with the patient established. After a partner or partners are notified, the DIS, along with the help from a patient and the provider, will work to refer them to a clinic, and that's to get some syphilis testing and presumptive treatment done. The CDC guidelines explain that sex partners to known cases of syphilis should receive both testing and treatment at the same visit. It is also a good idea to test that partner for other infections as well, HIV, gonorrhea, and chlamydia. So all of this workflow, everything will repeat if a partner tests positive. So they'll become a new case and they'll become in need of partner services again. And this is a lot of information as a provider who healthcare providers that are listening in. So please know that we are going to be advertising a line towards the end of this, and it's where you can contact us if you have any questions about this process. So don't feel overwhelmed. We're here to help. So I'd like to talk now about something that's really important and relevant to these cases. Health disparities, stigma, and the social determinants of health have all contributed to the increase of syphilis in women, and especially congenital syphilis. They're expressed in the complex interplay of poverty, cultural, language, and educational differences, social stigma, access to prevention and care services and other programs, housing, transportation, medical mistrust, as well as violence and trauma in families. These causal factors can best be summed as the major contributing causes to syphilis in women and congenital syphilis. When we talk about race, especially with epidemiology and statistics, it's important to understand that higher rates of syphilis are not caused by ethnicity or heritage, but by these complex social conditions we're talking about, and they're more likely to affect minority groups. Focusing on race can be useful, but it also perpetuates stigma and its long-term effects, and it doesn't get to the underlying problems that do need repair. But there is hope, knowing how complex these cases are. It's important that people across different sectors in our society really come together to prevent syphilis in our communities. And the Department of Health cannot do this alone. It'll take the work of providers, social workers, case managers, health educators, community organizations and leaders, everybody in this call right now. We all must work together to address this concerning rise. Prevention of syphilis within a community is really dependent upon our ability to promptly identify newly exposed individuals and taking the steps to interrupt transmission. So here are just some steps that you can take to reduce syphilis in your community. So if you're a healthcare provider listening in, reading our medical advisory that came out, congenital syphilis is increasing statewide. That's available on our website as well. And that really outlines a recommendation to test all women for syphilis at multiple points during their pregnancy. So that's first as early as possible during their pregnancy, again, between 28 to 32 weeks of gestation, and then again at the time of delivery. Outside of pregnant women, just testing women annually for syphilis, regardless of their intention to become pregnant. Also quickly reporting cases of syphilis and congenital syphilis so we can initiate our investigations promptly. And also calling our information line if you need a clinical consultation or to refer patients and their partners for partner services. For community members, you are incredibly invaluable as well. We recommend promoting screening for syphilis in the communities you work in, especially if you're working with clients who are pregnant, having that discussion with them. Making syphilis education a part of your community health programs, and that's something you can reach out to us and we can assist with that as well. Helping to address barriers to prenatal and antenatal care. We discussed that earlier, all those different things that impede quality care, and then also visiting our website where you can refer patients to as well to get some updated information about syphilis and reporting. This is the information line that I discussed earlier. So this is something that healthcare providers can utilize to get support with some of these issues. So first would be medical management. You can speak to one of our STD clinic providers in order to get information about diagnosis, treatment, or follow-up. You can also speak to one of our DIS to obtain clinical history, and that's to help you with staging. You can call to report, like I discussed earlier. And you can also call if you're unable to locate a patient who's in need of treatment and you need a little bit of assistance in doing so. And of course, sex partners, you can contact us if you need assistance in notifying sex partners of your patients. So that number is right there, 733-9281. And that flyer will be also in the attachments we send out after this. So post it in your nurse's station or above your desk. Just keep it handy because you might need to contact us one day. But I'd just like to say thank you so much. You being here really shows you've taken the initiative to learn more about this problem that's arising in our community. And so just thank you so much for being aware and for doing all that you can to protect the health of our moms and babies in Hawaii. My email is listed there, so please feel free to reach out to me if you have any questions. Thank you. So now I'd like to pass this off to Dr. Sharon Adler for her presentation.
Hello, everyone. I'm just going to get my slide set up for you. So happy to be with you virtually. I wish I was there with you in person. So aloha to all. Let's see if we can get this started. Okay, here we go. Get my timer started. So I'm here to provide an overview of some best practices in syphilis management. And I want to thank Acacia and Glenn Wasserman for joining me for this webinar. I've learned a lot about your local epidemiology, and having a wide group of people attending this webinar is really important to kind of understand the impact that this has had on various populations and to try and address this rising concern. So in terms of disclosures, I do not have any disclosures, and I'm going to jump right in, and I might need to turn my video off so I can see my whole screen, but okay, here we go. So syphilis, as many of you know, is caused by a spirochete, the Treponema pallidum bacteria. And this graphic depiction shows you kind of how initial infection takes place. It is transmitted by direct contact of the bacteria And typically people develop their primary manifestation of syphilis at the site of inoculation. So this is depicting an inoculation site on the penis, and that's where the chancre is developing. Very important that transmission can also take place from mother to child at any phase of the disease in the mother and at any time during the pregnancy, and it's also rarely bloodborne. Syphilis is really interesting in that it causes a systemic infection that is, has periods of active disease where you actually have clinical manifestations interrupted by periods of latent infection. And then there's this graphic depicts there's widespread dissemination through the blood and through lymphatics to any end organ. So basically any end organ system can be impacted by syphilis. This next slide goes over the natural history of syphilis. I want to highlight a few things. On the bottom here, in the red is basically just to let people know that we used to think that ocular or neurosyphilis or actually otosyphilis was something that needed to take many years to develop. And we now realize this could be an initial presentation of syphilis. So it can occur at any stage. Syphilis is quite infectious. So approximately 30 to 50% of people, if they're exposed, will acquire the infection. An incubation period is on average about a month, but it can be out to 90 days. And I want to say in terms of primary manifestations, those are classically the solitary ulcer that's indurated, that has minimal exudate, that's painless. These can go unrecognized. And so in women in particular, pregnant or non-pregnant, if it's in the vaginal area on the cervix and the vulva, or in someone who's engaging in receptive anal sex, it may go unrecognized and it will resolve on its own within a few weeks. Then the person goes into the period of secondary disease. And I'm going to be showing you pictures of the primary and secondary in a few moments. But secondary rash is one of the most classic manifestations. But these rash, if it goes undiagnosed, misdiagnosed, which is common because there's many things that it can mimic, these lesions will also resolve on their own without treatment. Then the person goes into the period of latent infection. And so during latent infection, the person has no clinical manifestations whatsoever. And this is why we screen certain populations for syphilis to try and pick up those latent infections, because really the only way to diagnose these latent infections would be by a blood test, a serologic blood test. And then the natural history of latent infection is that a small proportion, maybe 25% of people, can have a relapse, usually within that first year of their secondary manifestations. And so I always say when I teach about this, that I look at this as another opportunity for us as clinical providers to take a second look at that rash that this person's presenting with, or think about the alopecia that they may have and consider syphilis. So then the rest of the people who have latent infection, about 30% will go on and have tertiary complications, and these take place over many years. And I've been giving this talk on syphilis for many, many years. And I always say, we don't see tertiary in the United States, but we just came back from the National STD Prevention Conference, and there were a variety of case reports on tertiary that we're seeing. So we are seeing some aortitis. We are seeing tabes dorsalis. So you can have tertiary syphilis in the United States now because we're seeing so much syphilis. So here are some of my nice pictures. Here are some of the classic solitary ulcers of primary syphilis. Those are on the top row. And then if you look on the bottom here, we have some examples where syphilis can mimic other diseases. And so syphilis definitely can mimic herpes. You can have multiple shallow ulcerations. In women, here are some more classic examples of solitary ulcers, but also you can have multiple ulcers, excuse me. And then here's an example of some perianal, very shallow, small ulcers that are actually not herpes, and this is primary syphilis. As I said, the manifestation of this ulcer or chancre appears at the site of inoculation, and so you can have extragenital chancres. And so here are some examples on the finger, on the mouth, on the tongue, on the chin. All right, so now let's talk about secondary syphilis. So secondary syphilis, classic manifestation is rash, occurring up to 90% of the time. What I was taught in medical school was palms and soles, that's syphilis, and that occurs about 60% of the time. In addition, these patients feel unwell. They feel as if they've got a viral illness. They have lymphadenopathy. They have constitutional symptoms. They can have mucus patches. I'll show you some pictures of these, and Condyloma Lata, which can mimic warts. And then they can have alopecia. And as I mentioned, neurosyphilis is a rare phenomenon, but it can manifest early on. So in terms of the rash of secondary syphilis, it can pretty much appear at with any morphologic feature. And so classically, it's a macular papular copper colored rash. But you see here some examples of more papular pustular examples. You see these nickeled and dimed lesions on the scrotum in this male, and this is kind of where syphilis got the term being these annular lesions. I just said nickeled and dimed because that's an old term for kind of having syphilis is nickeled and dimed, but they're annular plaque-like lesions, and it kind of can mimic psoriasis. Here's an example of a palmar lesion. Here are some of the things that syphilis can mimic. And so tinea versicolor, pityriasis, a drug reaction, erythema multiforme because of the palmar lesions, and then guttate psoriasis, scabies, and viral exanthem. And so the classic teaching, and I really want to emphasize this, is that if someone who's sexually active comes in with a new onset rash, you always have to consider syphilis and get an RPR in those patients. Here are some examples of Lata. And so these are raised, moist, heaped up lesions that are typically occur in the anogenital areas. They can also occur in other moist areas of the body, intertriginous areas underneath the breasts. These definitely mimic warts. And so here's somebody who was thought to have warts, RPR was done and it was reactive. And so don't forget to think about syphilis, Condyloma lata, because it can mimic Condyloma acuminata, which is what causes warts. And these lesions, even if you try and freeze them, use TCA or use liquid nitrogen, they're going to resolve on their own anyway, but that freezing is not going to help them. And so you want to make the diagnosis, which is syphilis. Here are some other manifestations of secondary syphilis: the mucus patches on the tongue and the buccal mucosa, and then alopecia, which can be more diffuse or kind of moth-eaten, as in this example here. And then I was always taught, but I've never seen, is alopecia of the eyebrows. And so if that happens, that's kind of pathognomonic for secondary syphilis. I'm going to briefly mention neurosyphilis. As I said, it could occur at any stage of syphilis. We do know that asymptomatic central nervous system invasion takes place in everybody. Is common in early syphilis, but that standard therapy will cover this. Every patient who you're diagnosing with syphilis should have a good neurologic exam, and I'm going to share with you kind of a cheat sheet on a good neurologic exam. But some of the early symptomatic forms that kind of take place within months to a few years: acute syphilitic meningitis, which classically involves cranial nerves 6, 7, and 8. And so those are the ones that are extraocular movements and facial and motor weakness. Otosyphilis, which classically manifests as tinnitus, which is with or without hearing loss or just hearing loss. And then ocular syphilis. In the past 5 to 10 years, we've seen more ocular syphilis in the United States. There's a whole host of manifestations, uveitis being the most common. Anyone who has ocular manifestations and is being diagnosed with syphilis should be sent to an ophthalmologist. And so they can have flashing lights, they can have changes in their vision, they can have red eye. Other early symptomatic forms are meningivascular manifestations like stroke and altered mental status. The late forms that typically take 2 to 15 to 20 years, and tabies and general paresis are those that take more like 15 years. As I said, we really haven't seen very many, but we are starting to see them as we see more syphilis. And so tabies presents with posterior cord and column dysfunction. So patients can have ataxia, they can have lightning pains classically down their legs, they can have bladder and bowel dysfunction. So this is, so that's kind of the overview of neurosyphilis. And this is a nice kind of cheat sheet on neurosyphilis that's available at the California Prevention Training Center website. It's also on the California Department of Public Health website. So which patients do we want to send for a lumbar puncture to assess their CSF? And this is consistent across the CDC treatment guidelines and the HIV guidelines, in that it really is those patients who have neurologic, ophthalmologic, otologic symptoms or signs. We don't need to get a CSF exam just because somebody is HI infected, because that basically there's no evidence that getting that exam, looking at their CSF, improves outcomes at this point. We don't have data to support that. So it's those patients who have neurologic or ophthalmologic signs or symptoms, patients who have tertiary disease, or serologic treatment failure. We'll get to what that is in a little bit. So I want to review staging for syphilis, because this is really important. Staging determines treatment, and staging also influences partner management. So it's really important for the health department to kind of know what stage of syphilis was this patient. And when we think about a syphilis in pregnancy, the stage determines whether treatment has been adequate, because you want to treat based on stage. And so patients who are staged with primary or secondary they get different treatment than patients who are staged with latent disease. And so those patients who present with those Shankar manifestations, the rash, the alopecia, the Lata, they get secondary stage. And then you always want to do, as I said, a good neurologic, ophthalmologic assessment on all of your patients you're diagnosing with syphilis. Patients usually are identified as latent infection are those who have been screened for syphilis. And if someone comes up on a screening test and they need 2 tests, and we'll get to that in a moment, as having syphilis, you got to do a good head-to-toe exam and make sure there isn't a hidden lesion, say in a female. You got to do a speculum exam and make sure there isn't a hidden lesion in the vagina or on the cervix. In a male patient who's got receptive anal sex and he's engaging in that activity, you'd want to do an anal exam. And so we can't classify somebody as having latent disease until they've had a good examination and had a good history taken in terms of signs and symptoms. So latent disease is categorized as early latent if patients meet one of these criteria, and I'll go through those in just a moment. And early latent are patients who have been infected for less than 1 year. And the reason that staging is so important is that early latent disease, primary and secondary disease, they all get the same treatment. And their partners get worked up as partners to somebody who's got infectious disease. So the criteria that are used are if someone had a negative syphilis serology within the past year and now they have a positive syphilis serology, that is evidence of having early latent disease. A known contact to an early case, and this is where the health department can really help you on that. Good history of typical signs or symptoms in the past year, or a 4-fold increase in titer, and that's a sustained 4-fold increase over 2 weeks. And so these cases of 4-fold rise in titer could be reinfection if the person is sexually active, or it might be treatment failure, and they have to be kind of be determined on a case-by-case basis. Then the final criteria would be somebody whose only possible exposure was this year. And so that would be somebody who's newly sexually active and now has syphilis. So if you meet any of these criteria, you get staged as early latent. If you do not meet these criteria, your stage is late latent or latent of unknown duration. And they get a longer amount of treatment and their partners get treated differently. So very, very important. Staging influences treatment. All right, now we're going to move on and talk about the diagnostic approach. And this is a challenging area. I have a short amount of time, but I want to say this is the start of our learning communities. And for those of you who are going on to attend the other smaller sessions, we will go into greater detail about diagnostic approach. So for syphilis, it's not just the interpretation of serology. It's also, as I said, an assessment of symptoms and signs, an assessment of their sexual risk, and understanding their medical history. Have they been treated for syphilis before? Very, very important. And we're going to start this with a case study. And in a moment, you guys are going to get to vote and we'll have a poll come up, but not quite yet. So here's our case example. This is Stephanie. She's a 28-year-old female. She has this painless sore that she's had in her vulva, indurated, raised, minimal exudate lesion. She has some risk, but she's never had herpes or syphilis before. She had gonorrhea and chlamydia when she was younger. She has had 3 male partners in the past 6 months, and she's currently engaging in injection drug use. You're working at a facility where you actually could get a stat RPR, and the stat RPR comes up as being negative. And this probably would be in an emergency department setting or an STD clinic setting. So I'd like to get the poll up now, if that's possible. So you guys are going to get to vote. So how would you manage this patient? Is it choice A? Are you going to wait for her test results to determine treatment? And that would be sending off a quantitative RPR. Do we want to presumptively treat for syphilis now? Do we want to order a treponemal test on her? Or is it B and C, which would be presumptively treat and order a TPPA, or A and C? So I can't actually see if people are responding to this poll, but I hope people are responding. And we have maybe 75 to 80% of people responding who are there. I'd like to see the poll results. So I'll just wait a moment. And then if you could share the poll results, that would be great. All right, John, can we share the poll results? All right, interesting. 64% got the correct answer. That's fabulous. And so we definitely want to presumptively treat. So about 9% of you, 4 people said presumptively treat. And we definitely want to do this. This is a classic syphilitic appearing ulcer. It's indurated, it's raised, it's solitary, it's painless, and she's got risk. We want to treat. The other thing that we want to do is get a treponemal test, and we'll talk about that in a moment. So that would be the correct choice. And so let's go on with some management issues that take place in primary syphilis. And what this case example was demonstrating is that your serology may be negative in about 25% of the time in primary syphilis. And so you can consider ordering a treponemal test along with that, because treponemal tests may turn positive slightly earlier. Take-home point is on the bottom highlighted in red. If serology is negative and your suspicion is high, you want to empirically treat. And you can get a serology a week later. So I could obtain an RPR in her in a week, and that RPR may remain reactive even though it was negative early on, because treatment might not abort that RPR reaction. So take-home message, when someone presents with an ulcer, their serology, particularly their RPR, may be negative about 25% of the time. So now we're going to move and talk about diagnostics. The mainstay of diagnostics is down here at the bottom is serology. I'll just say that if you work in an STD clinic, some STD clinics have dark field. And this picture on the upper right is an example of what a dark field, how treponemal pallidum appears. PCR testing is not widely available, not yet FDA approved, but it's a direct test like a NAT test, and it can be useful for primary syphilis identification. So it's directly testing that lesion, might be useful for secondary, but not useful in terms of blood serum, plasma, or CSF. And so you're left with serologic blood tests for the vast majority of the time in terms of making a diagnosis of syphilis on a patient. And so there are two broad categories of serologic tests. We have our non-treponemal tests and our treponemal tests. And so the non-treponemal tests are the RPR and the VDRL. I'll talk about those in just a moment. And there's also the TRUST, which is not as widely used. Treponemal tests, they are the ones that have been around for many, many years, the FTA and the TPPA. And it sounds like that in Hawaii, the Department of Health has access to the TPPA, and that's great because that is the most sensitive and most specific test that's out there. And then there are a variety of automated treponemal tests, enzyme immunoassays, chemiluminescence immunoassays, and the microbead immunoassays. And these tests have some limitations, and we'll talk about those in just a moment. Take-home message here is that you need two tests. So you need both types of serologic tests to make a syphilis diagnosis. You cannot use one. And really just sometimes we start with a traditional algorithm. We start with the RPR. Other times we start with a automated reverse algorithm, and you start with a treponemal test, and we'll get to that. But you need two tests to make a diagnosis of syphilis. So this slide just kind of briefly goes over the non-treponemal test, the RPR. This is showing you what an RPR card looks like when the person's going to be reading out clumping of this charcoal. These tests are great because you get a titer with them that is useful to assess the burden of disease, useful to kind of, when you're following their titers, to see whether treatment has been adequate, and also useful to see if there's ever been a fourfold rise to detect reinfection. However, it is looking for an antibody that's directed against a cardiolipin lecithin antigen that is not specific to T. pallidum. It can be present in the blood of patients with syphilis, but you can also have in other people who have other inflammatory conditions going on. So you can have what's called biologic false positive results. That's where the RPR is positive, but your treponemal test is negative. And I have a slide that goes over kind of some common causes for biologic false positive results in a moment. I just want to talk about titers because we get lots of questions about titers. And so titers correspond to a higher level of antibody in the patient's serum. And we're not really concerned about a twofold rise, whether it's a rise or a decline, because that might be within the margin of test error. It might be between two different labs. What we're concerned about is a sustained fourfold change. And so if there's a sustained fourfold rise, you're concerned about reinfection or possibly treatment failure. So here's an example of a fourfold rise of a 1 to 2 to 1 to 8. If that was sustained, that would be concerning. A twofold change, a 1 to 16 to 1 to 32, not really concerning, would be within the margin of test error. The other really important point here is that you always want to compare the same test, serologic test titer with the same serologic test. So you'll want to compare the RPR to an RPR and a VDRL to a VDRL. And that's because the RPR can often be higher. And then you're kind of just comparing apples and oranges. And that really gets very challenging when you're looking at follow-up and you're looking at titers. So always compare the same serologic test. That will help you. So this slide is a graphic that depicts some of the common patterns of syphilis serologies. And this is just demonstrating, so when a person presents with their primary lesion, how it can take time. So only a small proportion of people are actually going to have their VDRL or their RPR that's reactive. The other take-home point from this slide is that the VDRL with treatment, those should decline fourfold over time, and we'll talk about that. Untreated doesn't decline as rapidly, but many, many, many years later may decline. So when someone has TAVIs, they may have an RPR that's unreactive. And then your treponemal tests can remain positive for life. So your TPPA, the FTA, and some of the immunoassay tests are going to remain positive for life. So there's a lot on this slide here. I just want to go over some key points just as reminders. The performance of the syphilis serologic tests. Primary disease, the non-treponemal test, about 25% of the time, may be negative in primary syphilis. The TPPA may turn positive slightly earlier. But the main take-home message here is that in secondary disease, when someone presents with their alopecia, the rash, the Condyloma Lata, the mucus patches, the thinking is that these tests are almost 100% sensitive. And so you can really trust your test. And there's one caveat, and with syphilis, there's always caveats. So that's a rare caveat. It's called the prozone. And this next slide goes over what the prozone is. And so I want to emphasize it's a rare phenomenon. It occurs maybe 0.3 to 2% of the time, more common in early disease like secondary, more common in HIV, persons living with HIV and neurosyphilis. But basically, if you look at this graphic on the right-hand side, so the RPR test is detecting the clumping of the chromogen, which is the charcoal here. And that clumping of the charcoal takes place because of these antigen antibody complexes that form. And you can imagine if somebody is so highly infectious, their body is producing so much antibody that can overwhelm this antibody antigen complex. And so if you have a patient where you're thinking this rash is definitively secondary syphilis, how come my RPR is negative? You might want to call the lab and just say, have you done the prozone? Have you diluted the serum a little bit? And if they do that, they should be able to detect a positive RPR. Okay, now we're going to shift and talk about the reverse sequence screening algorithm. And so I have another poll that I'm going to bring to you in just a moment. So this relates to the management of discordant serologic test results. And so we have an asymptomatic female who's being screened for syphilis, because in Hawaii, you guys are starting to do screening of reproductive age females. And the lab results come back as treponemal antibody positive, RPR non-reactive, and TPPA positive. So she said 2 treponemal tests that are positive, but her RPR is non-reactive. And so if you could pull the poll up, that would be fabulous, John. So what would be the next steps in her management? Do we want to obtain a history to assess for prior syphilis treatment? RPR is non-reactive, so no treatment is needed. If no prior syphilis treatment, she needs treatment. Is it one of those choices, or might it be A and B or A and C? And I'll give you guys a moment to answer, and I'll have a sip of water. And then about a minute, if you could open up the poll. Can you share the poll? All right, let's see what you guys said. Great, 94%. You guys know what you're doing. So yes, we always want to obtain a history to assess for prior syphilis treatment, and she needs treatment. 2 treponemal tests that are positive, even though the RPR is non-reactive, she still needs treatment. So that's fabulous. So that is just kind of introducing the 2 different screening algorithms for syphilis. People are probably very familiar with the traditional one. You start with an RPR. If the RPR is positive, oops, I skipped a slide. If the RPR is positive, it reflexes to a treponemal test. If the treponemal test is positive, we've got an RPR, which is a non-treponemal test, and we have a treponemal test that's positive. This person has syphilis, whether it be past or present. And let's move on and talk about the reverse screening algorithm, which is what our case example was an example of. And you guys kind of got it, so you know what we need to do. So she was screened initially with an automated treponemal test, an EIA. That EIA was positive. Her RPR was negative, and that's called discordant serologies. Most labs will automatically obtain a treponemal test. And then if this person has never been treated for syphilis, and the treponemal test in this case is positive, if she has never been treated for syphilis before, she needs treatment. If she has had prior syphilis treatment, she doesn't need treatment as long as there's not any risk for reinfection, new infection right now. But if she's never been treated for syphilis before, she would get treated, and it's usually staged as late latent, and get 3 doses of benzathine penicillin. But you would go through kind of a whole syphilis history and an exam to assess. I just want to share with you 2 nice guides that are up on the California Prevention Training Center website. One kind of goes into the interpretation of these treponemal assays, and one is on one of the rapid point of care tests, the syphilis health check. There's another point of care test that was just FDA approved, and so we'll probably end up getting a fact sheet on that one as well up on our website. But here's some nice resources for you. So I've already discussed all of these. I just want to review some of the diagnostic challenges that we have with syphilis. We talked about false negatives early on, and how if someone presents with an ulcer that you're thinking is syphilis, your serology may be negative about 25% of the time. The rare prozone reaction, and you can also get a false negative years into infection, untreated late latent disease. Biologic false positives, I haven't gone into great details on these, but these take place when you start with the traditional algorithm. Your non-treponemal test is positive, but the confirmatory test is negative. And this is due to some concurrent illnesses that are also detecting when we detect that non-specific cardiolipid lecithin antigen. And so concurrent viral illnesses, including HIV, recent immunizations, autoimmune and chronic diseases, and injection drug use in and of itself might lead to a biologic false positive result. Discordant serology, we went into some detail on this. And then I also talked about the fact that treponemal tests can remain positive for life. I haven't mentioned the fact that there are some specificity issues with the fluorescent treponemal antibody test. It's great to hear that you guys are using the TPPA as your confirmatory test. And so the FTA ABS test is one, because it's done by an individual laboratorian. You can sometimes have false positives because of specificity issues. All right, now we're going to segue and talk about treatment. And so I really emphasized earlier that staging is very important, and that's because we do stage-based treatment. So patients who are staged with primary, secondary, or early latent disease, adequate treatment for them is 1 dose of benzathine penicillin, and that's 2.4 million units IM in a single dose. We want to make sure that you're using Bicillin LA, that's the trade name of benzathine penicillin. You do not want to use Bicillin CR. It does not contain an adequate amount of the long-acting benzathine penicillin. Also important to note is that even those who are living with HIV do not need additional antibiotics. They can have the same treatment, and we'll talk about treatment in pregnancy in just a moment. Here are some alternatives that should not be used in pregnant patients. And these alternatives are a little bit complex to take. A medication, doxy, twice a day for 2 weeks, tetracycline 4 times a day for 2 weeks, or inject IV or IM ceftriaxone. All of these regimens are somewhat less studied and not well studied in HIV infected patients. And so you want to make sure that you do good follow-up. So then patients who are staged as having late latent disease or latent abundant duration, they get a longer duration of treatment. It's a total of 7.2 million units of benzathine penicillin that is given in 1-week intervals at 2.4 million units. And in terms of that interval, I want to emphasize here that in pregnancy, you have to really stick to that 7-day interval. In a non-pregnant patient, 7 to 9 days is ideal. And then the CDC says you can have a 10 to 14 day in a non-pregnant patient, but it's not as ideal as the 7 to 9 day. And we'll talk about why it's so important in pregnancy to maintain that 7-day in just a moment. In terms of alternatives, and these again are not in pregnancy, there are 2 regimens that have been not very well studied, but have been used for many years as alternatives. You have to have good follow-up in these patients because we don't know as well about their efficacy. So now I'm going to segue and talk a little bit more specifically about treatment of syphilis in pregnancy, and then we'll move to congenital syphilis after that. So as I said earlier, penicillin is the only treatment that can be used for syphilis in pregnancy. And in general, you treat with a regimen that's appropriate for the stage of infection. In early disease, the CDC treatment guidelines gives us a some experts recommendation, in that many experts are going to say, let's give 1 dose for the mom and 1 dose for the baby. And so you give a 2nd dose a week later. If a woman has a clear history of penicillin allergy, she's going to need to be desensitized and treated with benzathine penicillin. And as we go through these learning communities, I believe we'll have some case examples of how to manage patients like that. And then all patients with syphilis, whether they be pregnant or not pregnant, need to be tested for HIV. So looking at the interval time between doses in pregnancy. And so why is it so important to adhere to that 7-day interval? And this is when the 2015 treatment guidelines came out, they did kind of a back look at some of the pharmacokinetics of benzathine penicillin. And they found a study that demonstrated that in pregnant women, about 40% of them had levels of benzathine penicillin that were below treponemal after 9 days. And so they kind of hedged and said 7 days the interval that we want to keep. You have to restart that entire series of 3-week doses if a dose is missed. Other important issues in terms of syphilis in pregnancy are if you have somebody who's been diagnosed with syphilis in the second half of their pregnancy, you need to include an ultrasound. And so on ultrasound, some evidence of congenital syphilis would be hepatosplenomegaly, ascites, hydrops, fetal anemia, a thickened placenta. And all of these patients, if there is any evidence of findings on the ultrasound, are going to need to be managed with an obstetric specialist. And we're going to have one of our learning communities with an obstetric specialist kind of go over in more detail management. In addition, I'll talk about the Jarisch-Hersheimer reaction, which is an acute febrile reaction that takes place within 2 to 8 hours after getting that benzathine penicillin. But when you give it to women in pregnancy, particularly if in their second half of their pregnancy, they might be at risk for premature labor or fetal distress. And so women need to be informed about this and to seek medical attention if symptoms take place. But concern for this complication should not delay treatment. And so a little bit more detail about the Jarisch-Hersheimer reaction. Basically, this is when you get the benzathine penicillin, within the first few hours, the spirochetes are released and endotoxins may take place, may be released as well. And then the person may have kind of an acute inflammatory reaction. So they may present with headache, an exacerbation of their rash. They may think they're having, a terrible drug reaction to benzathine penicillin, but it's not that. You need to inform patients that this may take place, and that usually if they take Tylenol, it's going to, maintain things, reduce the fever that can occur as well. It's more common in early disease, uncommon in latent disease, and as I said, is not a drug reaction. Okay. I want to emphasize something, and I don't think I did this when we talked about treatment, but it's really important. It's going to make your interpretation of follow-up titers much easier. And that is anytime you give treatment, you want to get a day of treatment titer. So we know, because syphilis can mimic many other conditions, the day that you take that initial RPR test may not always be the day that you treat somebody. So say you have an example of a patient presented with an all-body rash. You were thinking it was a viral exanthem. You were not thinking it was syphilis. You got an RPR, and that RPR ended up being 1 to 256, and you realized, and then they had a confirmatory treponemal test. You realize this is syphilis. Patient comes in, gets treated. You do not obtain an RPR in that patient. 6 months later, you're trying to see, has that titer dropped 4-fold? We look at our titer 6 months later, it appears as if it has not dropped. But if you got that day of treatment titer, so maybe she came in 10 days later, it's usually a higher peak titer. It's often not checked. So the titers can rise dramatically in early syphilis. And so the day of treatment titer is very important. It establishes your baseline. And it's very useful when you're looking at follow-up titers to say, did my titer drop 4-fold? And so it's frequently forgotten and just makes interpretation of follow-up titers a little bit more challenging. So that moves us on to when do we do follow-up and what kind of serologic response are we looking for? So for patients who are staged primary and secondary, you want to see them back about a week later. We want to assess, has that rash improved, that alopecia improved? Is their ulcer going away? And then you want to get titers on them at 6 and 12 months. And then for persons living with HIV, it's more frequent titers. And we'd expect a decline in titer 4-fold by 6 to 12 months. It might be longer for persons who are living with HIV. And we'll talk in a moment about the follow-up and serologic response in pregnancy. For latent syphilis, it can take longer for those titers to drop, particularly if they weren't high, and those may not drop if they're not greater than 1 to 16. But these patients, you want to see them back at 6, 12, and 24 months, more frequently for persons with HIV disease. And we'd expect this 4-fold decrease to take place out to 12 to 24 months if the titer was initially greater than 1 to 16. And it might really be that 24 months for persons who are living with HIV disease. So specifically related to syphilis in pregnancy, you want to get titers at 28 to 32 weeks for patients that were diagnosed earlier in pregnancy. You definitely want to get titers at delivery, and then you want to follow after that based on the stage of the disease. If you have a woman that is deemed as being high risk and you're really concerned about reinfection and assessing for a fourfold rise, you might get titers monthly in someone who's high risk. The challenging thing in pregnancy is that most women will deliver before they've had time for that adequate serologic response, because that can take out 6 to 12 months, sometimes 24 months, if it's late syphilis. And as it appears based on looking at your data, you have a significant portion of patients who are being diagnosed with syphilis that it's late stage. But the clinical and serologic response should be appropriate for stage. Okay, so moving on now to congenital syphilis, which is what we all want to prevent, and it is a preventable disease. The risk of infection from the mother infecting the baby, the fetus, is really related to the stage of syphilis, and it's highest in primary and secondary. So women who acquire syphilis during pregnancy and have treponemal pallidum bacteremia are at highest risk of transmitting to the fetus. But you can still have fetal infections in pregnant women with late latent syphilis and low titers. And there's a whole host of manifestations. You can have stillbirth and miscarriage. I believe that occurs maybe 25% of the time. And then I'll move on and we'll talk about early congenital syphilis and late congenital syphilis. And so early congenital syphilis are those babies that who have manifestations before the age of 2. I want to emphasize that many babies at birth appear completely normal. Up to 2/3 of infants may be asymptomatic at birth, but if they're not treated, they will develop symptoms. And so I'm not going to be going into detail about the algorithms for determining whether this is a scenario 1 where the baby presents with kind of acute manifestations of congenital syphilis, or is it just that baby has a titer that's higher than the mother's, and was the mother treated adequately? These are all the different things that need to be considered in terms of making a diagnosis of congenital syphilis, and we'll be going into that in great detail in the learning communities. But I want to emphasize that babies can appear completely normal, and really doing a good evaluation of mother's treatment. Was it adequate? Was she treated by the stage? And did she have those 7-day intervals if it was late disease? And did that treatment take place more than 4 weeks before the baby was born? Because these babies that appear asymptomatic may develop symptoms if they're not treated at birth. And they can have bony abnormalities, they can have hepatomegaly, jaundice. I'll show you a picture of the skin rash and the nasal discharge. And here's a baby that's born with an ulcerative lesion on the umbilicus. The manifestations in terms of rash can mimic those that we see in adults. So here's a plantar rash, and then the syphilitic rhinitis, which is extremely infectious. Late congenital syphilis manifestations can take years to develop, 5 years to adulthood. And you can have hearing loss, loss of vision because of inflammation of the cornea, interstitial keratitis. This picture on the right is a picture of these Hutchinson's teeth, which is a tooth abnormality. You can have glomerulus disease, granulomatous inflammatory diseases that occur anywhere in the body. And here are some pictures of the kind of unfortunate stigmata of congenital syphilis. And these are not going to go away. These are kind of lifelong stigmata of congenital syphilis, which is why we want to prevent and treat early on. And so I want to emphasize that congenital syphilis is a preventable disease. We'll go over what the screening recommendations are in Hawaii. The CDC in general recommends you want to screen at least once, but in areas with high prevalence, you want to screen 3 times in pregnancy. And Hawaii is one of those states. There are many other states in the country that are dealing with this. If you have a mom that has not had prenatal care, you do not want to let her leave the hospital without obtaining a serology on that mom and on that baby. And also, very important, timely treatment of syphilis during pregnancy. If that mom is treated at least 4 weeks prior to delivery, we can really prevent cases of congenital syphilis. And so Acacia mentioned the Hawaiʻi Department of Health advisory that came out with recommendations on screening in pregnancy. This came out in August 2020. And you want to screen 3 times in pregnancy, as early as possible at that first prenatal visit, at 28 to 32 weeks, and then again at delivery. In addition, all babies that are born to mothers that have a reactive RPR and a treponemal test need to have a quantitative RPR. And then you want to screen at-risk sexually active women annually, regardless of the intent to become pregnant. So to close out here, in addition to pregnancy, which population should be screened for syphilis? I just want to emphasize pregnancy, but I also want to mention that men who have sex with men, including those on PrEP, should be screened annually or possibly more frequently, every 3 to 6 months if they've got high risk. Correctional settings, persons living with HIV and persons presenting to STD clinics are also settings where people should be screened for syphilis. So my take-home points, I want to emphasize that syphilis can mimic many other conditions, and you got to keep it in your differential diagnosis, knowing that in secondary syphilis, your tests are really great, and knowing some of the limitations of your diagnostics. It's staged-based treatment. Get your day of treatment titer that's going to make your assessment of follow-up titers much easier. Report all cases of syphilis to your local health department. And in Hawaii, that's within 3 working days. And they have lots of resources for you to support you. They've got a warm line to support you with questions. And then congenital syphilis is preventable. Screening 3 times in pregnancy is the way that we can get there. And I'm going to end. I think I'm going to stop sharing my screen because Ina is going to facilitate questions for all of the presenters right now. So thank you so much.
Hello, can you, I hope everyone can hear me. I wanted to thank you, Sharon, for a great presentation, very comprehensive. And as we know, syphilis is incredibly complex. And so we do have a lot of questions. I also want to thank Dr. Wasserman and Acacia Fukuda. And I'm actually going to go through some of the questions in the chat. And the first 2 are going to be for Dr. Wasserman, if he could unmute his mic and turn on his camera. Fantastic. So Dr. Wasserman, we had questions from Kristen Garrig, I'm sorry if I butchered your last name, asking how many total cases of syphilis did we have in Hawaii in 2019 and how many cases were in women?
Yeah, thanks, Kristen. There were 249 cases of syphilis reported in 2019. 86% of those were early syphilis. And 61 of the 249 cases, or 24%, were in women.
Okay. And Fenfeng Lee also asked Dr. Wasserman, when you talked about that slide that demonstrated that the vast majority of folks who were born with congenital syphilis resulted from inadequate treatment in the mother, did that really mean that the mother got no treatment at all, or that the treatment might have been incomplete? For example, she only got 1 out of 3 doses of bicillin if she was, you know, supposed to be treated with 3 shots for latent syphilis, for example.
Well, inadequate treatment includes both no treatment, as in a baby born to a mother with syphilis who had no prenatal care,
Okay.
and those with incomplete treatment. And there are many ways for there to be incomplete treatment. For example, the mother was treated with bicillin CR when she should have been treated with bicillin LA. The mother should have received 3 doses of bicillin LA 1 week apart for latent or unknown stage syphilis, but instead received 1 dose of bicillin LA for early syphilis. Or the mother was treated appropriately, but the baby was born less than 30 days after treatment.
Got it. So I think what I hear you saying is that there's a very diverse range of, you know, categories that would qualify as inadequate treatment, and it sounds like you had a big variety.
I think it's important to recognize that inadequate treatment does not necessarily mean that the healthcare provider gave inappropriate treatment.
Right.
Very often, inadequate treatment is due to the mother not coming in for care at appropriate times during her pregnancy for screening or care. And this is why social systems that impact social determinants of health and access to care are so important.
Absolutely. And, you know, one of the things that you guys talked about, and that one of your responses was increasing screening during pregnancy to hopefully catch folks prior to delivery and deliver treatment. And so these 2 questions, the next questions are actually for, oh, go ahead.
Yeah, may I add something that's also really important from a public health point of view? I just want to emphasize the importance of treating the partner, because if you don't treat the partner, then the patient can get reinfected. And this is really common, and the Department of Health can help with trying to track down the partner if that's needed, or support in this area. And also, in addition to treatment of the patient and the partner, it's very important to test for all STDs and HIV in both patients. And that's just a generality. If you have patient has one STD, you should probably test for all the testable STDs, and the same with the partner.
Absolutely. And those questions actually dovetail perfectly into the questions that I have for Acacia Fukuda. One where we talked about screening, because your guys, one of your responses is really to increase screening in both the first trimester and the third trimester and at delivery. So Acacia, do you know if Hawaii insurance plans or Hawaii insurers for the most part will cover the more frequent testing in pregnancy, as well as the recommendation to test non-pregnant people annually for syphilis?
Sure. So for pregnant women, they should be covering the increased testing from what I understand, as well as non-pregnant population. Well, not as well as non-pregnant patients. It's hard to say. There's a lot of variability between different insurance. I've heard that like Aloha Care and Ohana have agreed to cover the increased testing. And the U.S. Preventative Task Forces do, have it in their recommendations that asymptomatic non-pregnant adults and adolescents who are at increased risk for a syphilis infection should receive screening. So the question is, who is considered in that at-risk population? And so, just being aware of the prevalence of syphilis in our own community is important. But and I know that some insurance companies will adhere to the U.S. Preventive Task Force recommendations. It's hard to say exactly right now what the status is, but we're going to check on that, and we can get back to the group at a later time just to make sure and see if there's going to be any barriers for patients, such as copays.
Yeah. Have you heard anything from Kaiser about whether or not they'll be willing to cover if the health department recommends?
No, I haven't heard from Kaiser. That'll be something that we should check with as well.
And so another question for you, Acacia, one thing Dr. Wasserman mentioned was about, partner treatment and partner notification. And Peter Tui Silva was asking, could a provider notify a sex partner or a needle sharing partner of a patient, if that patient wanted the provider to notify the partners, as opposed to the health department?
Yeah, that's a great question. I mean, we do want to reduce the amount of barriers it takes to notifying that partner, but we're recommending that what providers do is, to be involved in the process, you can elicit that partner information from the patient and pass it on to the Department of Health. That can be done usually through a case report, or you can call us as well. Just because we, this is different for each provider, but, we tend to have a lot more experience in doing it, and we can do it in an anonymous way. So that might be challenging if the partner knows that you are the provider for a particular patient. But providers, like in the military, have done notifications with the patient's consent. But, if you have any questions about that, we can help. If you need advice on how to do those partner notifications, we can help too. But you should just really consider the situation that you're in. It's going to vary from case to case and sort of decide what's appropriate from then on. But, we're here to provide advice.
Yeah, and maybe we can put, can you tell us that number again, Acacia, for everybody?
Sure. So our information line is 808-733-9281. Yes, that's it. And I'll send out through the California Prevention Training Center. I know you folks have agreed to send out a few documents for us after, so I'll include a flyer with that information as well.
That's perfect. Great. So another question, both for Dr. Adler and possibly for Dr. Wasserman or for Acacia, about one thing that you brought up, Dr. Adler, was a case of a patient who had a negative RPR who had primary syphilis. And the question is about can you specifically order a TPPA when you're sending a suspect case, if you're ordering it from a private lab? And then the question for the Hawaii folks would be, is there a workflow where a provider could actually order a TPPA from the get-go for a patient that they're suspecting with primary syphilis from the Hawaii State Lab? So Dr. Adler, do you want to start first?
Yeah, I would hope that there's a way to say that. I know that many labs on the mainland were able to just order specifically a treponemal test and don't have to reflex it from the RPR or the VDRL. So I don't know the logistics in Hawaii specifically. I'm hoping that maybe Acacia might know. Sounds like you guys have TPA testing at the Department of Health. I don't know about for other settings like Kaiser or other settings in Hawaii.
Dr.
Actually,
Wasserman, yeah.
yeah, actually, we only have a few select clinics that can submit specimens directly to SLD. So a lot of people submit them or to other labs, which get sent perhaps out of state, which can take a little bit longer. We're currently working on that issue that's come up recently. But for the time being, that's where we're at.
Okay.
I would say the take-home message is if you suspect syphilis, even if you're waiting for your test results, you're going to presumptively treat. So, you may, that sounds like it may take a little time to get a treponemal test, but you want to presumptively treat if you've got a high epidemiologic risk or just a classic manifestation of syphilis.
And there's quite a few clinical questions, and because I was concerned we were going to run out of time, I actually answered a couple of them, but if you want to comment, Jason Yaris asks, can some patients bypass secondary symptoms completely during, during this whole natural history of syphilis?
Yeah, I mean, it's very individual. The person's own immune system is going to determine kind of what response they're going to have in terms of how dramatic their primary manifestations are going to be or not, and how dramatic the secondary manifestations are going to be. And so they could be, they could basically go straight into latency and go unrecognized. So yes.
Yes.
Is that what you said, Ina? Hopefully.
Yeah, I did say that. And I was just going to point out that I had a patient a few months ago whose only manifestation, he had 3 tiny little spots of a rash on his scrotum. And that was it. The rest of his body was completely clear. So I think people can have very subtle manifestations.
Yep.
Laura de Vilbis asks about, these tests can often be positive in other treponemal, endemic treponematosis like yaws. And she was just saying, can you comment about, positive test results in a condition like yaws?
Yeah, and so that is something that you guys in Hawaii probably have to deal with more than we do on the mainland as well. So yaws and pinta are treponemal tests that you can have a false positive result for the TPPA, the FTA, or any of the other treponemal tests. And so I think that you may not be able to use that as your confirmatory test. You may be just left with the RPR, the VDRL. And maybe there's no way to distinguish on that treponemal test, whether it's yaws or pinta. But trying to inquire about history of yaws or pinta may help facilitate an understanding what's going on in that patient. And I don't know if Glenn wants to kind of give more detail, because it's not something that I've ever.
So about 20 or more years ago, that was a more common issue that's come up. Nowadays it's a lot less common to be a concern, but the medical history is important.
Yep. And then, I think this is Babe Ruth Gehring is asking about, is 14 days an acceptable interval for non-pregnant patients? Is that the new guidelines? So if you could comment on that, Sharon.
Yeah, no, that's not the new guidelines. It's been in the 2015. They say 10 to 14 days is okay anecdotally. Ideally, it's 7 to 9, even in a non-pregnant patient. But on a case-by-case basis, if someone goes out to 14 days, that may be okay. You definitely want to follow their titers and see, and you really want to try and get them in sooner then. But we realize that some patients, it may be really challenging to get them in at that 7-day interval. And so this is again in a non-pregnant patient. And that's in the current guidance. I don't know the 2021, whether there's going to be a shift in that. I don't anticipate that, but it's been in the guidance for a while now.
Yeah. And I'm sorry, Sharon, because the questions were coming in like near the end of your talk, so you didn't get to see them all in advance, but I'm happy to weigh in. I think you seem to be comfortable with all of these, but another question about, if a patient came in and their titer was previously 1-to-1, let's say, and they came in less than a year later, and now they have a very high titer, 1 to 1,052 with no symptoms. The question is, should the patient get 3 bicillins or just 1? The patient has a history of HIV and was treated adequately in the past.
So what you're describing is one of the categories of early latent disease. So this person meets criteria. If they had a titer that was 1-to-1, they've had prior treatment, and now they have a 4-fold or more, and we'd expect that would be a sustained 4-fold rise. And with a 1 to 10 to 54, I think that's probably a sustained rise that she meets criteria or he meets criteria for early latent disease. And so it would be 1 dose of benzathine penicillin that would be adequate treatment for that patient. And that's why that categorization of latent disease is early versus late, and they get different treatment because this patient has got evidence of having infection for less than 1 year.
Yeah. So Yeah, that's great. And so another question and a clarification point from Kristen Gerg. For patients who had a new sexual partner and wanted to be screened, like say for syphilis, it's a little bit different for the other bacterial STIs, but how long do you recommend after their encounter, do you actually recommend them having screening for syphilis? And then once they're positive and treated, how long do you ask them to abstain from having sex? Assuming their partner, they have a main partner who also gets treated.
Right. No, so in terms of screening for syphilis, I mean, there's specific populations that you want to screen in. I don't know if I would generally screen somebody who just wants to be screened for syphilis, but if you want to, if they meet any criteria to be screened, we know the incubation period can be out to 90 days. So depending on what their risks are, you might screen them today and just say to them, this is telling us about your history prior to that most recent encounter. And then if you want to know whether you've got syphilis, you'd have to wait that 90 days to screen them because of that 90-day incubation period.
Yep.
And the second half of the question, I actually can see it. I'm looking at, so how long once positive do you recommend abstaining from intercourse? So here's where, you definitely want to get those partners in. Thank you, Glenn, for mentioning that. I didn't have a whole section on partners. I was trying to include a lot of content. But
You have an enormous amount of content.
Treating a partners is, STD 101. You got to get those partners in and treated. So it will depend on what stage they are. So syphilis is transmitted to sex partner by those infectious lesions. So it's transmitted by that ulcer. It's transmitted by a moist Condyloma Lata lesion or mucus patches. And so in those patients, I would assume, 7 days after they have been treated and their partners have been treated and those lesions are gone, then I'd say they probably are not infectious to others. Patients who are staged as late latent, they don't have any manifestations. It's less important in terms of transmission to partners. Mother to child, always in late latent, but from sexual partners, you don't need to worry about it. I don't know if, Ina, you want to add anything to that?
No, I mean, we typically, typically we would tell someone if they had primary, we give them their bicillin and say, you have to wait at least a week, but if you have an open lesion still, then you need to wait until it's all healed over. But so at least a week, and the same for secondary. The question is, and I think actually Dr. Wasserman and Acacia and Dr. Adler, we all have experience with this. A pregnant woman who doesn't finish their 3 bicillin injections, how many times do you need to restart the series?
Over and over. Unfortunately.
Yeah.
Really trying to work with them to come in for those, shots. But, as Dr. Wasserman and Acacia mentioned, there are many other overlaying factors that are beyond just getting them in and get to the doctor's office for those treatments. And so that can make it very challenging.
So, I mean, I have definitely seen cases where women have had to start the series, 3 times during pregnancy before completing it, and plenty of cases where folks actually never completed the series.
Yes.
And those folks, unfortunately, will have to be worked up, and their babies will count often as a congenital case, at least by the surveillance case definition, if their mother is not treated.
I know there was a question about adequate and inadequate, and that's where somebody might meet criteria for not having adequate treatment. Right. If they never got their 3 doses within that 7-day interval.
Yeah. So can I provide a point of clarification that might be interesting to folks, is that Kristen Gerg happens to be from Kaiser, and so mentioned that Kaiser is covering, or at least she thinks that Kaiser is covering screening 3 times in pregnancy, because their OBGYN department chief actually sent that out to say we should do this. And so it sounds like that's probably covered by health plan. Last question. I think the question that about that patient who had a 1-to-1 and they their treatment was not able to be done exactly, at a year, or they went a little bit longer, would they actually need to get 3 bicillins, or is it still okay to give 1?
In terms of when they started the treatment?
Yeah, I think the point is that as long as the serology is done a year apart, if the patient actually is a little bit, doesn't come in for 3 weeks or whatever to get their shot, you would still consider them early.
The window should be adequate in that case.
Okay. Yeah, so we're saying just 1 shot for that patient. And I think, okay, I have to look through and make sure we got all of the questions. I think that's it, and we are at time. That is a miracle.
Yeah.
So I want to thank everybody. I just wanted to mention there was a small error in the CME slide. Forgive me, it is actually 1.5 units of CME because you have been with us for 90 minutes. So thank you. The slides were, a PDF of the slides were actually sent out, but on the website where you registered on the NNPTC website for this actual event, we will actually post a link to the PDF of the slides there as well. And then we will be communicating with all the participants here to send out some of the great information that the Hawaiʻi Department of Health has about how to report and their number, you know, to talk to their STD program if you want to talk about partner notification or about a congenital case.
Okay, and again, we want to thank the California Prevention Training Center for this great support for communicating, you know, treatment and making sure that people are clear as to what the treatment is and the workup is for syphilis. And we have an important problem now and we need to address it. And thank you for helping us with this.
Thank you. It's our pleasure. Well, thank you, everybody. We really appreciate your attention, and we are going to sign off and let you enjoy the rest of your days. Thank you.
Dr. Park, really fast, can I just promote the learning community one more time with the group? Yeah, sorry. So after this week, it'll be taking place on Tuesdays, but October 20th, 27th, November 10th, and November 17th, all from 12 to 1 p.m. Hawaii Standard Time. We're going to be having a learning community just to further delve into this topic of testing, diagnosis, and treatment of maternal and congenital syphilis. So the CMA will be available at no cost. And this is really intended for healthcare providers who work with pregnant women and newborns from communities that are facing cultural, economic, and language barriers to obtaining good prenatal and neonatal care. So we will, I think we can still send an invitation out for that. It's going to be available on a limited basis, so we do have to approve participants, but please register that you can still register for this event.
Oh, great, Acacia. And,
Thanks, Acacia.
we'll be talking about, you know, challenging cases and how to manage them as well in a, you know, smaller environment with just providers, so we can really hammer out some of the difficult intricacies of managing these cases. Thank you, everybody.
Bye.
Thank you so much.
Bye.